Okay, let's unpack this. We hear a lot about blocked arteries in the legs. That's pretty common knowledge, right? Lower extremity arterial disease.
Yeah, exactly. A big topic.
But what about the arms? It turns out, problems with arteries up there are far less common,
That's true.
but maybe even more impactful on your daily life.
That's the really critical distinction, I think. While upper extremity issues are less prevalent, maybe 5 to 10% of those really limb-threatening events.
Okay.
And that classic plaque buildup, atherosclerosis, it's just not as frequent up there as down below.
Right.
But when it does happen, the consequences for just, well, functioning day to day are huge. We rely so much on our hands and arms for almost everything.
And that reliance is exactly why we're doing this deep dive today.
Yeah.
Into something called upper extremity arterial occlusive disease.
Mm-hmm.
UEAO for short.
UEAOD, yeah.
We've got a stack of pretty detailed sources here, including a really comprehensive chapter just on this to help us figure it out.
And our mission, really, is to be your guide through this, well, complex area. We want to pull out the most important bits of knowledge, maybe some surprising facts,
Yeah.
and help you get a solid handle on what UEAOD actually is, why these arteries get blocked, and, what can be done about it.
So let's start right there. Why does this matter so much, even if it's less common than the leg stuff?
Well, the numbers are pretty clear. Maybe under 5% of the symptomatic arterial disease we see is actually atherosclerosis in the upper limbs.
Only 5%. Wow.
Part of that is because the arm has this really good network of backup vessels, collaterals.
Mhm.
They can help keep blood flowing even if there's a blockage.
Ah.
But despite that relative rarity, if you get a significant blockage,
Yeah.
well, that means impaired arm and hand function. Just think about simple tasks: writing, cooking, getting dressed.
Yeah, everything.
Losing the use of a hand or arm impacts your independence in a way that's arguably more immediately debilitating than, say, losing some function in a leg.
That makes sense.
So that's why figuring out what's wrong quickly and treating it promptly is just vital. Absolutely vital for saving the limb and keeping it working.
Okay, paramount for limb salvage and function. Got it. But before we get into what goes wrong, could you give us just a quick overview? The main blood vessel highways in the arm. Keep it simple.
Sure, let's trace the route. So blood comes from the aorta up in the chest, travels into the subclavian artery. Then, as that artery crosses over the first rib, it actually changes its name. Becomes the axillary artery.
Okay, axillary in the armpit area.
Exactly. Then, down past the armpit, it becomes the brachial artery in the upper arm.
Brachial. Got it.
At the elbow, it splits into the two main forearm arteries, the radial on the thumb side and the ulnar on the pinky side. These run down, and then, interestingly, they join up in the hand to form what we call the palmar arch.
A loop in the palm.
Sort of, yeah.
Yeah.
And that feeds the fingers. But it's interesting, in maybe 1 in 5 people, that arch isn't fully connected. Yeah. So if one of those forearm arteries has a problem, the hand might not get enough backup flow from the other side. Something to keep in mind.
Okay, good point. So you've got this network of pipes, and then something stops the flow. And the what goes wrong part here is really, really eye-opening. The list of causes is just so varied.
It truly is. It's not just one simple thing blocking the pipe, like you might think.
Let's start with the classic one, the one we know from heart disease or leg problems. Atherosclerosis. That plaque buildup, you said it's less common here?
That's right. Plaque does build up in arm arteries, definitely, but just less frequently than in the legs.
Okay.
When it does, we start considering it significant if it narrows the artery by about half, 50% or more.
And what does that do?
Well, that narrowing makes it harder for blood to get through, causes a pressure drop downstream, and this can lead to what we call claudication.
Claudication, that's the cramping, right?
Yeah, a cramping, tired, or heavy feeling in the arm or hand, especially when you use it, like carrying groceries, brushing your hair, that kind of thing.
Makes sense.
You might also notice the hand feels cool, or maybe the pulses are weaker than the other side.
And is there a specific spot where this plaque likes to build up most often in the arm area?
Yes, that's a key point. The most frequent location for significant atherosclerosis affecting the arm supply is right where the left subclavian artery comes off the aorta, way up high.
The left one specifically.
Often the left, yeah. And if that gets really narrowed or blocked, it can lead to something called subclavian steal syndrome.
Subclavian steal, that sounds dramatic. What's happening there?
It kind of is, biologically speaking. Blood flow to the arm might still be okay at rest, but the body achieves this by, well, stealing blood.
Healing from where?
It reverses the flow in the nearby vertebral artery. That's an artery that's supposed to send blood up to the back of the brain.
Whoa.
So blood gets diverted down from the brain's supply to feed the arm, especially during exercise.
Wow. Does that cause stroke symptoms then? Like dizziness or vision problems?
Not typically, actually, unless the person also has significant narrowing in their carotid arteries, which supply the front of the brain.
Ah, okay.
Usually the brain's collateral circulation, its backup system, can handle it, but the arm itself might still not get enough flow during activity, causing that claudication. And there's another risk.
What's that?
Little bits of that plaque or clot from the subclavian blockage can break off and travel downstream. Emboli.
And block smaller vessels.
Exactly, causing mini blockages, often down in the fingers, digital embolization.
Okay, so that's the slower plaque-driven narrowing, especially that subclavian steel issue. What about a sudden, like, bam, blockage?
That's usually due to an embolus that's a clot that travels from somewhere else.
Right, the trap.
Or a thrombus, which is a clot that forms right there in the artery itself, often on top of existing plaque.
Okay.
When that happens suddenly, blood flow can drop way down below the critical level needed to keep the tissue alive. This causes sudden, often severe pain and can quickly lead to tissue damage, even gangrene, if it's not fixed fast.
Scary. And where do these sudden clots, these emboli, usually come from?
Most often, the heart, or the big vessels right near it, like the aorta.
The heart, why?
Conditions like atrial fibrillation, AFib, that irregular heartbeat. Blood can pool in the heart chambers and form clots.
Yeah, okay. Makes sense.
Also, clots can form after a heart attack or if there are problems with heart valves, or sometimes even after medical procedures like cardiac catheterization or certain heart surgeries.
It's mostly heart-related.
Mostly, but not always. Less often, they can originate from plaque breaking off from the aorta itself, or sometimes they're related to widespread infection, sepsis, and sometimes we just can't find the source. It's a mystery in a surprising number of cases.
Interesting. So we've got plaque, we've got sudden clots. What about when the body's own immune system kind of turns on itself?
Right, that's where vasculitis comes in. This is a whole group of inflammatory diseases where the body attacks the walls of blood vessels. They get inflamed, thickened, sometimes damaged, or even destroyed.
And does this happen often in the arms?
Upper extremity involvement is actually less common for many types of vasculitis, but it definitely happens and can be quite severe when it does.
What are some key examples we should know about?
Well, they're often grouped by the size of the vessels they affect. So small vessel vasculitis often links up with autoimmune conditions like lupus or rheumatoid arthritis.
Okay.
It tends to show up more as skin issues, rashes, or problems in the fingers and hands, things like Raynaud phenomenon.
Where the fingers turn white or blue.
Exactly.
Yeah.
Or painful ulcers, even gangrene in severe cases. Then there are medium vessel types, which less frequently involve the arms, things like polyarteritis nodosa. But for the arms, the large vessel types are probably more relevant to our discussion.
Like Takayasu and giant cell arteritis? I've heard of those.
Exactly. Takayasu arteritis typically affects the aorta and its main branches, and the subclavian artery is a really frequent target for narrowing or blockage.
Okay.
And a key feature here, it primarily affects younger people, usually under 40, and predominantly Asian women. That's a classic demographic.
Interesting. And giant cell.
Giant cell arteritis, also called temporal arteritis, is similar pathologically, but usually affects branches of the carotid artery more, like the ones in the scalp, hence the temporal name. But it can affect arm vessels, too. This one is more common in older women, usually over 50.
Different age groups.
Right. And both can cause arm claudication, pain even when resting, and skin breakdown if it gets bad.
And then there's one called Buerger disease. That one sounds particularly nasty.
It is. Thromboangiitis obliterans, or Buerger disease, is a distinct and really severe inflammatory process. It affects small and medium-sized arteries, but also veins and even nerves, mainly in the hands and feet.
Wow, veins and nerves, too.
Yeah. Clinically, it looks a lot like very severe atherosclerosis, often leading to terrible pain, skin breakdown, ulcers, and unfortunately, a really high rate of gangrene and amputation. It's a devastating disease.
And what's the absolute strongest link with Buerger disease? Is there one major cause?
Tobacco use. Overwhelmingly. It is almost universally linked to smoking or using other tobacco products. If you see burgers, you think tobacco.
Almost always.
Almost always. And it predominantly affects young men, typically under the age of 35. And unlike many other types of vasculitis, it usually stays confined to the limbs. It doesn't tend to affect other organ systems.
Okay, so plaque, sudden clots, inflammation. What about just, like, physical forces, wear and tear, or outright injury?
This is where things get really surprising for a lot of people. Trauma injury is actually the leading cause of acute upper extremity ischemia.
Wait, the leading cause. More than plaque or clots from the heart.
That's what the data indicates for acute ischemia, meaning sudden lack of blood flow.
Wow.
Now, this includes the obvious stuff, acute trauma like gunshot wounds, knife wounds, severe blunt injuries from accidents, or fractures and dislocations that tear or crush blood vessels.
Okay, major injuries.
Right, and those require immediate attention to prevent catastrophic bleeding or limb loss. They also carry a big risk of something called compartment syndrome.
Compartment syndrome, what's that?
That's when swelling inside a muscle compartment, the space enclosed by tough tissue, gets so bad it literally squeezes the blood vessels shut. It's an emergency itself.
Yikes. But it's not just major accidents, right? You mentioned repetitive motion trauma.
Absolutely. And this is where it gets really relevant to everyday life and work. Prolonged use of vibrating tools. Think jackhammers, chainsaws.
Yeah.
That vibration can actually damage the small arteries over time, causes them to narrow, makes them prone to spasm, or even clotting.
So your job could literally damage your arteries.
It can. And we see similar issues in other professions or even hobbies involving repeated strenuous hand activity, maybe intense typing, playing certain musical instruments, some sports.
Like pianists or typists.
Potentially, yes, if it's intense and repetitive enough over a long time. There's even a specific condition called hypothenar hammer syndrome.
Hypothenar hammer.
Yeah. It happens when people repeatedly use the heel of their hand, the hypothenar eminence, as a hammer. Think mechanics banging things into place, carpenters, some athletes even.
Using their hand like a tool.
Exactly. It can cause direct injury to the ulnar artery running through that part of the palm, leads to a clot forming or a bulge and aneurysm developing in the artery wall, and then that can send small clots down into the fingers, causing ischemia.
Fascinating. And sometimes the trauma actually comes from medical care itself.
Unfortunately, yes.
Yeah.
We call that iatrogenic trauma injury during a medical procedure.
Like what?
Things like cardiac catheterization, where they go through an artery, or inserting arterial lines, those catheters used for close blood pressure monitoring in the ICU, or even creating or accessing a dialysis fistula.
Right.
These procedures can sometimes cause a clot to form right there, or cause bleeding, or accidentally send little clots downstream embolization, or even create a pseudoaneurysm.
A pseudoaneurysm, what's that?
It's like a leak in the artery wall where blood escapes and forms this pulsating pocket or lump right next to the vessel. It's contained by the surrounding tissue, not the artery wall itself.
Okay.
And this iatrogenic injury is particularly risky in situations where maybe the hand's natural backup blood supply, that palmar arch we talked about, isn't great.
So trauma is this huge, diverse category, from a major accident to your job or even a necessary medical procedure. Wow. What about simple pressure or pinching? Can that cause problems?
It can certainly be a factor, yeah. In what are called neurovascular compression syndromes, the most well-known is probably thoracic outlet syndrome, or TOS.
TOS? Heard of that one too.
That's where the bundle of nerves, artery, and vein that go down the arm gets squeezed as they pass through a narrow space near the collarbone and the first rib. If the artery gets pinched, it can definitely lead to flow problems, sometimes even clot formation or aneurysm due to the chronic irritation.
Okay. We've covered a lot of ways arteries get narrowed or blocked. What about the opposite problem, like bulges in the artery walls? Aneurysms.
Right, aneurysms. They are actually quite rare in the upper extremity arteries compared to, say, the aorta down in the abdomen.
Less common up here.
Much less common. And while the risk of one bursting in the arm is pretty low, though usually catastrophic if it does happen, the biggest threat from an arm aneurysm usually isn't rupture.
What is it then, if not bursting?
It's the tendency for blood clots to form inside that bulging, often turbulent sac.
Clots forming inside the bulge.
Exactly. And then those clots, or pieces of them, can break off and travel downstream, embolize into the smaller vessels of the hand and fingers.
Causing sudden blockages further down.
Precisely. That can cause sudden, painful loss of blood flow, leading to tissue damage or gangrene in the fingers or hand. It's the distal embolization that's the main worry.
And what causes these arm aneurysms?
Can be atherosclerosis, just like narrowing. Trauma is a big one, especially injuries related to the first rib or the collarbone causing damage to the subclavian or axillary artery. Infection used to be a cause, like from syphilis, but now it's more often seen with IV drug use or infected puncture sites. Sometimes it's chronic injury from something like a cervical rib, an extra rib, or a fibrous band causing repetitive damage. And certain genetic conditions affecting connective tissue, like Marfan syndrome, can predispose people.
Okay. What about faulty plumbing connections? Abnormal links between arteries and veins?
Ah, you mean arteriovenous fistulae or malformations, AV fistulas or AVMs.
Yeah.
Those are direct connections, like a shortcut between an artery and a vein, bypassing the normal capillary network.
Okay.
They can be congenital, something someone's born with, or they can be acquired. The most common acquired ones are probably the fistulae created surgically for hemodialysis access.
Right, for kidney failure treatment.
Exactly. Or sometimes they happen after penetrating trauma, like a stab wound that injures an artery and vein lying next to each other. These connections tend to enlarge over time because of the high arterial pressure flowing directly into the low-pressure vein, and they can sometimes steal blood flow from the tissues further downstream.
And finally, just wrapping up the causes. Some people just inherit a tendency for their blood to clot too easily.
Yes, absolutely. That's called a hypercoagulable state or a thrombophilia.
Okay.
These can be inherited genetic disorders like factor V Leiden deficiency or protein C or S deficiency, or they can be acquired conditions often associated with certain cancers or blood disorders like polycythemia or thrombocytosis where you have too many platelets.
So their blood is just naturally stickier.
In essence, yeah, it makes them more prone to forming clots spontaneously, sometimes without any other obvious trigger. Someone with this might have a history of blood clots elsewhere, like deep vein thrombosis, DVT in their legs, or pulmonary embolism.
Wow. Okay. That is an incredibly broad spectrum of ways blood flow to your arm can get messed up, from heart rhythm issues to using a jackhammer to having a specific gene mutation. It's a lot.
It really is.
So when someone comes in, maybe their arm is cold, painful, weak. How do doctors even begin to sort through all these possibilities? How do they figure out which one is the culprit?
Well, it always starts with the story, just listening carefully to the patient.
The history.
Exactly. What are their symptoms? Is it sudden, or has it been creeping up slowly? Is the pain worse with activity, or is it there even when they're resting? Do they notice color changes, pale, blue, red? Is the arm cold? Do they have a history of trauma? Even minor repetitive stuff. Smoking history, heart problems, other medical conditions like diabetes or autoimmune disease. All those clues are vital.
Then actually looking and feeling the arm.
The physical examination is absolutely key. You look for any obvious signs of trauma, wounds, bruising. You look for muscle wasting, which suggests a chronic problem, or swelling, which might suggest an acute issue or maybe a venous problem alongside it. And the skin.
Looking closely at the skin. Is it cool to the touch compared to the other arm? Is it pale or maybe bluish? Cyanotic? Are there open sores, ulcers, or even signs of gangrene, that black dead tissue? Is the skin shiny and hairless, which can happen with chronic poor circulation?
The feeling for pulses.
Crucial. Feeling the pulses systematically, starting from the neck, carotid, checking the subclavian area, the upper arm, brachial, the wrist, radial and ulnar, and even trying to feel pulses in the hand if possible. Comparing one side to the other is essential.
And you mentioned blood pressure difference.
Yes, that's a really important one. Taking blood pressure in both arms. A significant difference, say more than 15 or 20 millimeters of mercury, strongly suggests a blockage higher up in the subclavian or axillary artery on the side with the lower pressure.
Okay.
You'd also feel carefully for any pulsating lumps that might be an aneurysm or a pseudoaneurysm. And checking if the muscles feel very tight, hard, and painful to passive stretch, that could indicate compartment syndrome.
Are there specific tests doctors might do just with your hands during the exam? Yes, the Allen test is a classic and really important one, especially if they're thinking about doing any procedures that involve the radial artery, like for arterial lines or heart caths, or before certain hand surgeries.
How's that work again?
It's pretty simple. It checks if the two main arteries supplying the hand, the radial and ulnar, are both open and connected properly through that palmar arch. The examiner presses firmly on both the radial and ulnar arteries at the wrist to stop the blood flow. Then they have you clench and unclench your fists several times until your palm looks pale.
Right.
Then, while still holding pressure on one artery, say the radial, they release the pressure on the other artery, the ulnar. They watch to see how quickly color returns to the whole hand. If the hand flushes pink quickly, it means the ulnar artery and the arch are doing their job. Then they repeat it, holding the ulnar and releasing the radial.
So it checks the backup supply.
Exactly. If color return is slow or incomplete when one artery is released, it suggests the palmar arch isn't complete or the released artery isn't contributing much flow, which is important information.
Okay. What about other basic tests, like imaging?
Well, some basic tests might include a chest x-ray that can sometimes show bony abnormalities like that cervical rib we mentioned that could be causing compression, or it might show signs of heart problems like an enlarged heart.
And heart tests.
An EKG, electrocardiogram, is standard. It checks the heart rhythm, looking for things like atrial fibrillation that could be a source of clots. If a heart source is strongly suspected, an echocardiogram and ultrasound of the heart is often done. It can directly visualize the heart chambers, look for clots inside, check the valves, and see how well the heart muscle is moving. Sometimes a T, transesophageal echo, gives an even clearer view.
And blood work, what are they looking for there?
Blood tests can give a lot of clues. They might check for markers of inflammation like ESR or C-reactive protein, which could point towards vasculitis. Specific autoimmune markers like ANA or rheumatoid factor might be checked if autoimmune disease is suspected. They'll usually check for standard atherosclerosis, risk factors, cholesterol levels, blood sugar for diabetes. If there's a suspicion of an inherited or acquired clotting disorder, especially in a younger person with no other risk factors, they'll do a hypercoagulable workup, testing for things like factor V Leiden, protein C, protein S, antithrombin levels, and of course, basic pre-op labs if intervention is likely.
Okay, so you get clues from the history, exam, basic tests. How do you then look directly at the blood vessels themselves non-invasively?
That's where the vascular lab studies really shine. These are non-invasive tests, meaning no needles or dyes going directly into the artery being studied. A key one is measuring segmental arterial pressures.
Pressures at different levels.
Exactly. They put blood pressure cuffs at different points on the arm, upper arm, forearm, sometimes wrist or fingers, and measure the pressure. Normally, the pressure should be pretty similar all the way down. A significant drop, again maybe 15-20 mmHg or more, between one level and the next indicates a blockage or narrowing somewhere in that segment. They often calculate a wrist brachial index, similar to the ankle brachial index used for legs.
Okay.
They can also measure finger pressures using tiny cuffs. Low finger pressures can indicate problems further down in the hand or digits. And crucially, they use Doppler ultrasound.
Doppler, that listens to blood flow.
Uses sound waves to detect blood flow and can even show the direction and speed. The sound of the blood flow changes if there's a blockage. It might sound harsh or turbulent or disappear completely. They look at the waveform shape too, which gives clues about obstructions upstream.
And duplex scanning.
Duplex ultrasound combines that Doppler flow information with a B-mode ultrasound image, like the kind used for pregnancy scans. So you can actually see the artery wall, see if there's plaque or clot inside, measure the diameter, and see if there's a bulge like an aneurysm or an abnormal connection like an AV fistula.
And use color.
Right. Color flow Doppler adds a color overlay onto the image, usually red for flow towards the probe, typically arterial, and blue for flow away, typically venous. It makes it really easy to visualize where blood is flowing. If you see an artery segment with no color in it, that means it's blocked. If you see swirling colors or a sudden change in color shade, it often indicates a narrowing stenosis with turbulent flow through it.
So these non-invasive tests are pretty powerful first steps.
Absolutely. They are often the crucial first steps to confirm there is an arterial problem, get a good idea of where it is and what it might be, plaque, clot, aneurysm. They help guide the next steps.
Okay, so you've done the history, exam, basic tests, the non-invasive vascular lab scans. What's considered the sort of definitive test, the most detailed way to map everything out if needed?
Well, the traditional gold standard for detailed evaluation, especially when intervention is planned, is angiography. Catheter-based angiography.
That's the invasive one.
Yes, this is an invasive procedure. Typically, a catheter is inserted into an artery, often in the groin or maybe the other arm, and threaded up towards the aorta and into the arteries supplying the arm of interest. Then they inject a special contrast dye, which shows up on x-rays, and take a series of rapid pictures.
Like a movie of the dye flowing.
Exactly. It gives a very clear, dynamic picture, like a roadmap of the entire arterial tree, often from the aortic arch all the way down to the tiny vessels in the fingertips. It shows precisely where any blockages, narrowings, plaques, emboli, aneurysms, or abnormal connections like AV malformations are located.
It can show those specific patterns you mentioned earlier for things like vasculitis.
Yes, angiography can be very helpful there. It might reveal characteristic patterns like those smooth, tapered, narrowing seen in Takayasu, or maybe unusual corkscrew-shaped collateral vessels that can develop with Buerger disease.
And a big plus you mentioned.
A huge advantage of angiography is that often, once the problem is clearly identified on the images, they can proceed immediately to treatment during the same procedure.
Treatment right then and there.
Yeah. If they see a tight narrowing, they might be able to perform angioplasty, use a balloon to open it up, or place a stent. If they see a clot, they might be able to use a device to remove it or infuse clot-busting medication. It combines diagnosis and therapy.
That's efficient. Are there alternatives to that kind of invasive mapping if maybe someone can't have the dye or the procedure?
Yes, there are definitely less invasive alternatives that provide excellent images these days. CTA, which is computed tomography angiography.
Like a CT scan with dye.
Exactly. Uses X-rays and intravenous contrast dye to create detailed 3D images of the arteries. And MRA, magnetic resonance angiography, which uses MRI technology, sometimes with a different type of contrast agent.
Are they as good?
They can be excellent for diagnosis. CTA is often very quick and gives great bony detail too, which is helpful for TOS. MRA avoids radiation. But they both have considerations. CTA involves radiation, and the standard contrast dye can be tough on kidneys. MRA can be problematic for people with certain metal implants or severe kidney disease due to the gadolinium contrast risk, and it takes longer. They're primarily diagnostic. You can't usually treat during a CTA or MRA.
And for that giant cell arteritis?
Right. For suspected giant cell or temporal arteritis, even with imaging, the definitive diagnosis often still relies on a biopsy, taking a small surgical sample of the temporal artery from the scalp and looking at it under a microscope for the characteristic inflammation.
Okay, so a really thorough diagnostic process to figure out the specific cause. Once you know what's happening, what are the main ways doctors actually treat these problems? What's in the toolkit?
The management really depends heavily on the underlying cause, the severity, and whether it's an acute emergency or a chronic condition. But generally, the approaches fall into three main buckets: medical management, catheter-based interventional procedures, and traditional open surgery.
Let's start with medical approaches.
Okay. This includes treating any underlying systemic disease. So for atherosclerosis, it's aggressive risk factor management. Stopping smoking is number one, controlling blood pressure, managing cholesterol and diabetes, diet, exercise. If the problem is vasculitis, like Takayasu or giant cell, it often involves medications to suppress the inflammation, like steroids or other immunosuppressant drugs.
And treating vasospasm, like in Raynaud's.
Yeah, for vasospastic problems like severe Raynaud phenomenon, the first step is avoiding the trigger, usually cold, keeping the hands and body warm. If that's not enough, medications that help relax the blood vessels, calcium channel blockers like nifedipine are common first choices, sometimes others like prazosin. Good skin care to prevent ulcers is also important.
And stopping habits that contribute. You mentioned tobacco for burgers.
Absolutely critical. For Buerger disease, stopping all tobacco use, including smokeless tobacco and nicotine replacement, is non-negotiable. It's really the only thing proven to halt the progression of the disease. For anyone with arterial disease, smoking cessation is paramount. Addressing illicit drug use, especially IV drug use, which can cause infections or direct artery injury, is also key, if that's a factor. And protecting the limb from further injury, avoiding occupational trauma if possible, using proper technique in sports, ensuring careful placement of arterial lines, avoiding tight dressings.
What about medications specifically aimed at clots or blood flow?
Right. If the cause is an embolus from the heart, like an atrial fibrillation, long-term anticoagulation blood thinners is usually necessary to prevent future clots. Warfarin has been the standard, requiring INR monitoring, but newer direct oral anticoagulants, DOACs, are often used now. The goal is usually an INR between 2 and 3 for warfarin.
And if the clot source is plaque?
If the problem is related to emboli coming off plaque in a larger artery, like the aorta or subclavian, or for general atherosclerosis prevention, antiplatelet medications are typically used. These make the platelets less sticky. Aspirin's the classic one. Clopidogrel is another common choice. And of course, managing pain is a big part of medical treatment, especially with acute ischemia or severe chronic disease.
Okay, so managing the cause, lifestyle, specific meds for spasm or clotting. What about procedures that aren't full open surgery, the catheter-based stuff?
Those are the endovascular or interventional procedures. They're done via catheters inserted into an artery, usually in the groin or sometimes the other arm, and guided up to the problem area using X-ray imaging.
Like during the angiography?
Often, yes. If there's a fresh clot causing an acute blockage, they might use thrombolytic therapy. This involves infusing clot-dissolving medication, like TPA, directly into the clot through the catheter. This can sometimes break up the clot and restore flow, either as the main treatment or sometimes before or after another procedure.
Are there risks with clot busters?
Yes, the main risk is bleeding, elsewhere in the body or at the puncture site. There's also a risk of distal embolization if pieces break off, or sometimes vessel spasm. Careful monitoring is needed.
What else can they do with catheters?
If there's a narrowing caused by plaque stenosis, they can perform percutaneous transluminal angioplasty, or PTA, that's the balloon.
Balloon angioplasty.
Right. They pass a catheter with a folded balloon across the narrowed segment, inflate the balloon for a short time to stretch the artery open and compress the plaque against the wall, then deflate and remove the balloon.
And sometimes they leave something behind.
Yes. If the angioplasty result isn't perfect, or if the narrowing is long or likely to spring back, recoil, they might place a stent. This is a small, expandable metal mesh tube that's deployed across the lesion to act like a scaffold and hold the artery open. Stents can significantly improve the results, especially in larger arteries like the subclavian.
Is atherectomy used much in the arms? Removing plaque?
Atherectomy devices, which physically remove or vaporize plaque using lasers or rotating blades, are used more commonly in the legs. They can be used in the upper extremity in select cases, but angioplasty and stenting are generally more common for upper limb stenosis.
Okay. And then there's traditional open surgery. When is that needed?
Surgery still plays a crucial role, especially for certain situations. If there's a long, complex blockage, particularly in the larger arteries like the subclavian or axillary, or if endovascular treatment fails or isn't suitable, then bypass surgery might be the best option.
Creating a detour.
Exactly. They surgically create a detour around the blockage using a graft. For larger proximal arteries, this might be a synthetic tube made of materials like PTFE or Dacron. For blockages further down, especially below the elbow, the patient's own saphenous vein, usually taken from the leg, is often preferred as the graft material because it tends to stay open longer in smaller vessels.
Any other surgical options for narrowing?
For a short, localized area of plaque, especially if it's easily accessible, like in the brachial artery bifurcation at the elbow, they might do an endarterectomy, surgically opening the artery and physically scraping out the plaque.
What about that sympathectomy you mentioned? Cutting nerves.
Surgical sympathectomy, where they cut the sympathetic nerves that control blood vessel constriction in the arm, is sometimes considered for patients with severe ischemia, especially involving the small vessels of the hand who have failed other treatments and have severe pain or non-healing ulcers. The idea is to cause maximal vasodilation. However, its role is pretty controversial now, and the relief, particularly for pain, is often temporary. It doesn't fix the underlying blockage.
And for those sudden acute blockages from clots, you said embolectomy.
Yes, for an acute arterial occlusion caused by an embolus, that traveling clot, the preferred initial treatment, especially if the limb is immediately threatened, is often emergent surgical thromboembolectomy, or just embolectomy.
So you surgically go in and just pull the clot out?
Precisely. It's often done relatively quickly. They make a small incision in the artery, usually the brachial artery at the elbow, pass a special catheter with a small balloon on the end, a Fogarty catheter, pass the clot, inflate the balloon gently, and then pull the catheter back, dragging the clot material out with it. They might pass it both up and down the artery to clear as much clot as possible.
And that restores flow quickly.
Hopefully, yes. The goal is rapid restoration of blood flow to save the limb. After embolectomy, patients usually need to be anticoagulated, often starting with heparin intravenously, to prevent more clots from forming.
What about surgery for aneurysms or injuries?
For aneurysms, surgery usually involves resecting, cutting out the dilated, weakened section of the artery and replacing it with a graft, either synthetic or vein, to restore normal flow through a healthy conduit. Sometimes, for small aneurysms that aren't causing problems, they might just be monitored. For traumatic injuries like lacerations or tears, prompt surgical repair is critical to stop potentially life-threatening hemorrhage and restore blood flow.
How do they repair an injured artery?
Techniques vary depending on the injury. A clean cut might be repaired by suturing the edges directly back together, primary repair. If there's a hole or a segment is damaged, they might use a patch of vein to close the defect without narrowing the artery, vein patch angioplasty. Or if a segment is destroyed, they might need to insert a short piece of vein graft, interposition graft. The key is careful handling of the vessel, removing any damaged tissue, and ensuring a smooth repair that allows good blood flow.
That's a really comprehensive toolkit of treatments, from meds to catheters to open surgery. Let's try to bring this all together with that case study you mentioned earlier, the 87-year-old woman who came in with a sudden problem in her arm.
Right, so she presents with sudden onset of a painful bluish cyanotic right arm. On exam, she has no pulses detectable below the axilla, the armpit area. Her known history includes atrial fibrillation, and she's supposed to be on warfarin, the blood thinner, but it's noted her appetite has been poor lately.
Okay, let's connect the dots here. Her history and her presentation, what stands out immediately as the likely scenario?
Well, the combination of known atrial fibrillation and being on warfarin immediately flags the possibility of a cardiac embolus, a clot forming in her heart due to the irregular rhythm.
Even though she's on warfarin.
Yes, because the effectiveness of warfarin is crucial. The fact that her appetite has been poor raises a big red flag. Warfarin's effect is highly dependent on consistent vitamin K intake, which comes largely from food, especially green leafy vegetables. If she hasn't been eating well, her vitamin K intake might be low, making the warfarin less effective than intended. Her INR...
blood test measuring clotting time.
Exactly. Her INR level might have dropped below the therapeutic range, usually 2.0, 3.0 for AFib, meaning her blood wasn't thin enough to prevent a clot from forming in her heart.
Okay, so high risk for a clot forming and traveling. And the symptoms. Sudden pain, blue color, no pulses.
Those are the absolute classic hallmarks of an acute arterial occlusion. Blood flow has suddenly been cut off to the limb. Given her history and the suddenness, the most likely cause is that a clot formed in her heart, broke off, traveled up the aorta, and lodged in a major artery in her right arm. Probably the brachial or axillary artery, given the pulse findings.
So, based on everything we just discussed about treatments, what is the urgent priority for her? What needs to happen right now?
This is a true vascular emergency. With an acute embolic occlusion causing limb threat like this, the pain, the color change, the lack of pulses, the gold standard and most urgent intervention is emergent surgical embolectomy.
Get that clot out fast.
Get that clot out as quickly as possible. Time is tissue. The longer the limb goes without adequate blood flow, the higher the risk of irreversible muscle damage, nerve damage, and potentially limb loss. They need to restore perfusion urgently.
And what happens after that critical procedure, assuming it's successful?
Post-operatively, she'll almost certainly be started on intravenous heparin immediately. That's a fast-acting anticoagulant to prevent any remaining clot from propagating and to prevent new clots from forming while her circulation recovers.
Okay.
Then, once she's stable, they'll need to transition her back to long-term anticoagulation, likely warfarin again, or perhaps one of the newer DOACs. And this is where patient teaching becomes absolutely crucial, especially for an older patient who already had issues with maintaining therapeutic anticoagulation.
Right, because the underlying problem, the AFib, is still there.
Exactly. She needs to understand why she needs the blood thinner, how critical it is to take it consistently, why regular INR monitoring is essential if she's on warfarin, and how profoundly things like her diet, especially those vitamin K containing foods and other medications or even supplements, can interact with warfarin and affect her INR level.
This really raises that important practical question. Just how challenging is it for patients, especially maybe someone older like her, to manage warfarin and diet carefully over the long haul?
Oh, it can be incredibly challenging. It requires real dedication and constant vigilance from both the patient and their caregivers, if involved. Patients need detailed education about which foods are high in vitamin K. It's not just leafy greens, it's in many things, and the goal isn't to avoid them, but to keep their intake reasonably consistent from day to day, week to week.
Consistency is key.
Yes, because the warfarin dose is adjusted based on their typical diet. Any significant change, eating way more salad one week or getting sick and barely eating the next, can throw the INR way off. Add in things like starting antibiotics, certain pain relievers, even some herbal remedies like St. John's wort. They can all interfere. It demands a lot of communication with their doctors, pharmacists, and the anticoagulation clinic or lab.
So that teaching part is huge.
It's absolutely essential for long-term success and preventing another devastating event like the one she just had. It needs to be clear, repeated, and involve family members if possible.
It really sounds like the patient care after the urgent procedure is just as critical as the procedure itself. What are some other key things involved in living with UEAOD or recovering from an event like this from a care perspective? Nursing care, for instance.
From a nursing perspective, after intervention, it's all about meticulous monitoring. Frequently checking the 5PS, pulselessness, pallor, pain, paresthesia, numbness, tingling, and paralysis movement in the affected arm and hand. Comparing temperature and capillary refill to the other limb. Any deterioration needs immediate reporting.
Protecting the limb, too.
Absolutely. Protecting the limb from injury is key. Keeping it positioned correctly, usually neutral or slightly elevated depending on the situation, but avoiding sharp bends. Ensuring no tight bandages, IV lines, or blood pressure cuffs are constricting flow. And as we touched on with trauma, always monitoring closely for signs of compartment syndrome, especially after blood flow has been restored to a previously ischemic limb. Reperfusion injury can cause significant swelling. Pain management is also a huge priority.
Okay. And then for the patient, once they're hopefully recovering and going home, what are the really crucial takeaway messages they need for prevention and self-care moving forward?
They need, first off, a really clear understanding of their specific diagnosis and the risk factors that contributed to it. If it was atherosclerosis, they need to know that managing blood pressure, cholesterol, diabetes, and especially stopping smoking is lifelong. If it was an embolus from AFib, managing the AFib and the anticoagulation is the priority. If it was trauma-related...
Maybe the jackhammer.
Well, maybe. Or at least understand the connection. Avoiding or modifying the occupational or hobby-related trauma that might have contributed is key. This might involve changing tasks, using different tools, wearing protective gear, or taking more breaks. They need to know the overall goals: keeping blood flow healthy, maintaining arm and hand function, and avoiding complications like infection or reblockage. Medication management, as we've stressed, particularly if they're on blood thinners or antiplatelets, is huge. Understanding why they take each med, how to take it correctly, potential side effects, and importantly, what to watch out for in terms of interactions or problems.
So that detailed discussion we had about warfarin, vitamin K, INR checks, that's real-world, need-to-know stuff for them.
Absolutely. It's life-saving information, along with knowing which other common medications, even over-the-counter ones, can interfere. Beyond diet and meds, they need practical safety advice for home. Avoiding tight clothing or jewelry on the affected arm. Protecting the limb from bumps, cuts, burns, especially if they have any lingering numbness or reduced sensation. Good skincare, using moisturizers to prevent cracking. If they're on blood thinners, they should carry some form of identification stating that, and they need to be extra cautious about activities that could cause falls or head injuries and know when to seek immediate medical attention if they hit their head. And crucially, they need to know when to call their doctor or seek help. What do signs of infection look like around an incision or wound? How do they tell the difference between normal bruising and bleeding that needs attention? When should they worry about changes in the arm's color, temperature, sensation, or strength? What if they have new symptoms or problems getting their medication or concerning blood test results? Empowering them with this knowledge is critical for self-management and preventing future crises.
Wow. That truly was a deep dive into the arterial system of the arm, wasn't it?
It definitely covers a lot of important ground.
We've seen that while this upper extremity arterial disease is, yes, less common overall than problems down in the legs, its impact on just the things you do every single day can be absolutely immense. And we explored its surprisingly diverse range of causes. It's not just one thing. It ranges from that classic plaque buildup and clots traveling from the heart to these specific inflammatory conditions often tied to certain demographics and really significantly various forms of trauma, even subtle repetitive trauma from jobs or hobbies.
And we traced that journey to diagnosis, starting with really listening to the patient and a careful physical exam, moving through those really useful non-invasive tests like duplex ultrasound that can see inside the vessels, and often culminating in angiography, which serves double duty as both that detailed map and often a first step in treatment.
Right. And we saw that managing these conditions involves this whole spectrum of approaches, from treating the root causes with medications and crucial lifestyle changes like stopping smoking, to using sophisticated catheter-based techniques to dissolve clots or prop open narrowings, and sometimes needing essential surgeries like bypasses or that emergent clot removal, the embolectomy.
And understanding all these details isn't just, academic exercise. It's really about recognizing the potential for these problems, maybe in yourself or someone you know, advocating for a thorough assessment if concerning symptoms arise, and just appreciating how much goes into preserving that incredibly vital function of our arms and hands.
Absolutely. So considering that significant and maybe often unexpected role that trauma plays, everything from serious accidents to that repetitive stress from work or hobbies, here's a final provocative thought for you, our listeners, to maybe chew on. What are the broader implications here for understanding and maybe even preventing UEAO in specific jobs or activities that you know about? What situations might you encounter maybe in your own life or in the lives of people you care about, where recognizing even subtle signs of poor circulation in an arm could actually be a really critical piece of knowledge?
Something to think about looking at the hands and arms you see and use every single day.
Thanks for joining us for this deep dive.